All right, I was struggling to come up with a Valentine's Day joke yesterday all day. I couldn't think of one for class. But as soon as I got home, I remembered one. So I share it with you today, a day late, but hopefully still topical. Especially when you get to the endo section. But my favorite pharmacy-related pickup line is, "Hey girl, are you an insulin needle? Because you're ultra fine." Feel free to use that one. My wife's a pharmacist, so it must have worked out okay.
I thought the joke was that it was a day late.
Huh?
The joke was that it was a day late.
No, that's not the joke. That's a pretty bad joke, yeah. That's pretty bad. Anyway, okay. Let us continue. Any questions from yesterday? From our ending of the room stuff, and then we got on to talking about pain management. All right, so we're going to go look at our pharmacologic options here. So we're going to talk about acetaminophen, a very common one, kind of bread and butter sort of analgesic. Talk about our NSAIDs, opioids, and then finally our adjuvants. This is where we get into things like our TCAs, antiepileptics, muscle relaxers, all those other good kind of sort of additive drugs, maybe used by themselves, but a lot of times they're going to be used as an adjunct with some of these other agents. So anyway, acetaminophen, Tylenol, if anyone, I'm sure I've mentioned this before, but where they get that name Tylenol from is the TYL and the ENOL and that acetyl para-aminophenol. That is the full chemical name for Tylenol. So wow your friends with your great pharmacy knowledge. Anyway, it's good as an analgesic and antipyretic, so you kind of get dual benefit from that standpoint, and we use it a lot for mild to moderate pain. So think about kind of really mild aches and pains. You know, think about a pain scale 1 to 3 kind of range is really good for things like acetaminophen. We use it a lot for osteoarthritis because again, it lacks a lot of the side effects you run into with like NSAIDs, do from like a GI standpoint, from a bleeding standpoint, and generally pretty well tolerated. And actually, one of the things we're using nowadays is an IV formulation. We're using this a lot in our post-op patients. And what they've actually found in some studies is if you get a single dose of IV acetaminophen, it's a Affirmative, you can actually reduce the total amount of opioids that a patient needs during their stay. And the less opioids patients are on, usually the less side effects they have, the quicker they get recovered and they get out of the hospital. So we're starting to see more use of that. It's a lot more expensive than a typical, suppository or a tablet of Tylenol, but we're starting to see some good efficacy from it in the studies, so you may see that being used occasionally. Also really good for patients who can't receive things orally or rectally, because obviously if you can't do it orally, we still have acetaminophen suppositories. A lot of patients may not like that from a just ease of use standpoint. Please make sure they take off the foil wrapper first. It may seem intuitive, but some people are not that intuitive. Anyway, otherwise it's a pain in the butt. It's no good, right? And what type of patients would be contraindicated from receiving rectal medications? You remember anyone we talked about? Yeah, immunosuppressed, like neutropenic patients, especially because, again, why do we worry about that? You worry about some rectal trauma that could cause translocation of those gut bacteria right there at the rectum, and so that could cause infection. So that's one of the things you may. So we use this a lot for our HEMONC kids. So if they're coming in, they're neutropenic, we'll put them on IV Tylenol, and especially if they're oral, can't tolerate oral medications or MPO for whatever reason, that's a really good option we can use for them. And so we consider that opioid sparing, and that's generally a very good thing because the fewer opioids we can give our patients, the better off they're going to be from a whole host of standpoints, as we'll see here when we get to the opioids in just a few minutes. So you're going to find that we don't know the full mechanism for how it's working. Some people think it's working kind of more centrally, but we know we don't get a lot of good anti-inflammatory effects at the site of inflammation like you would for something like an NSAID. So you don't really get that kind of benefit from there. Really doesn't have any anticoagulant effects either, so from a bleeding standpoint, it's going to be pretty safe on that. And the only real big thing to worry about is that chronic overdosing or with an acute overdose, you worry about the hepatic damage that can happen. So again, we said 4 grams, typically our daily amount max. We don't want our patients to exceed. Again, if they have liver disease, then you may want to back that back down to something like 3 grams because you can still see chronic damage being done if they take it pretty routinely. Some people take the stuff like clockwork, throughout the day, and that's where you can see some damage being done kind of in the long term. And then you have to consider all sources of acetaminophen. It's really, really important that you make sure that you kind of elucidate if they're taking outside acetaminophen in addition to some of the other opioid products that we're receiving. So for instance, hydrocodone/acetaminophen, very common, probably one of the most widely prescribed medications for pain, probably #1 opioid. is being used for that. Oxycodone / acetaminophen. So there's lots of different sources there. Even tramadol has a form that has acetaminophen in it. So you need to get all those sources and make sure they're not going to exceed that. The nice thing nowadays with a lot of electronic medical record systems, from an inpatient standpoint, they'll actually will hard cap them from getting too much, and so it'll actually be able to calculate how much they're getting with every dose, no matter what drug they're getting, and it'll actually hard lock the nurses out from administering the drug. It'll say, hey, they've already received their 4 grams, you can't do any more today, right? Of course, that only works if the nurse is like scanning things before they give the medication, which doesn't always happen, as you'll find they try to do workarounds and things like that, where they'll give the medication first and they scan it, they're like, oh wait, it's wrong. And they're like, well, it kind of bypassed the whole safety process there. But anywho, so again, make sure you're considering all sources there. Make sure they're not getting too much. All right, now with NSAIDs, you're going to get analgesic, antipyretic, and anti-inflammatory properties. These are good for injuries because it can work directly at that site, as we saw in kind of the slides yesterday. Again, we know most of them are, there's a lot that are available as prescription only, but we have several that are OTC. And one of the OTC ones? Naproxen's a good one. Ibuprofen, those are 2 of the big ones, and then aspirin as well. We can still consider aspirin kind of being in this NSAID sort of category. And we know how they work, blocking activities of cyclooxygenase 1 and 2, and thereby decreasing their prostaglandin synthesis. So again, we're pretty familiar with that. Again, looking on this pathway, laser pointer, you see here is blocking cyclooxygenase, so that you're not getting a lot of your prostaglandins. Primarily is what we're kind of focused on here, but certainly with thromboxanes, prostacyclins will also be affected as well. So looking at the different categories we have here, so we have aspirin, as I mentioned. We'll consider aspirin kind of separate from the other NSAIDs insofar as the toxicity profile is a lot different, as we'll see in a few minutes here. But we mentioned ibuprofen or naproxen, but we also have other drugs like indomethacin. We have ketorolac or ketorolac. Most people probably call it ketorolac, but the actual pronunciation is ketorolac. Anyone know the brand name for that? Toradol is actually the brand, not tramadol. Tramadol is a very different drug. So again, look-alike, sound-alike drugs are super important to keep an eye on, because you don't want to mix those up. Because tramadol, while also an analgesic, can has opioid-like properties, whereas Toradol does not. So be careful with that. Tolmetin. So I'll go over a couple of other examples here in just a few minutes. You'll find that chemically there are different classifications of NSAIDs, and just because one patient does not respond well to ibuprofen doesn't mean they may not respond well to Toradol. They won't respond well to something like meloxicam. You may have to try a few different options to see kind of what's going to work best for them. And we have a variety of different dosage forms. We have IV ones that are available. Toradol is a very common one, or ketorolac is a very common one. We use IV and IM. There's some rectal formulations, but primarily most of these are going to be oral. We even have IV ibuprofen nowadays, and we'll actually use that occasionally in the NICU to help close up patent ductus arteriosus. We'll use that occasionally as well. Anyway, but again, try to give them a couple weeks of trial to see kind of how they're going to respond to it. And again, a lot of patients may have their pain relieved just fine by the drug, but they may need to switch off because the side effects are intolerable. So kind of keep that in mind as well. All right, so our common side effects. We're about GI upset, but certainly due to inhibiting that prostaglandin synthesis, we're going to inhibit that gastric barrier. It's so important to keep that stomach acid from eroding the gastric wall. So decreased mucus production there in the stomach, chances for NSAID-induced ulcers. Anyone know how you treat an NSAID-induced ulcer? Stop giving them an NSAID, right? That's going to be one of the best ways we can do it. We'll see some other drugs you can use as well. But again, if you have a drug-induced problem, take away the drug. Most of the time it's going to help to fix most of your issues. We'll see decreased platelet aggregation. Now, which one of these agents we kind of mentioned do you think has the most propensity for bleeding? Okay, so here's some aspirin. Why do you think aspirin?
1 and 2.
Yes, irreversible. So you'll find that it's non-selective, much like a lot of our other NSAIDs. However, it's irreversible in its effect on cyclooxygenase. So because of that, even if I stop taking, if I take aspirin every single day and then I stop taking it, I can still see effects of the drug occurring as long as that cyclooxygenase is still being inhibited until you produce new enzymes. Okay, all the other NSAIDs that we have are going to be reversible, which means as long as the drug is out of the system, it should not be having any effects on your platelets. Okay. So that's important because, again, if you're having bleeding associated or bruising associated with NSAIDs, stop giving it to them, and chances are it'll go away as soon as the drugs, it'll correct the problem itself once the drug's out of the system. However, aspirin not going to be quite so easily fixed from that standpoint. So can see some hypersensitivity, not super common with this group of drugs. And then we'll see they can actually prolong gestation. So again, we mentioned that NSAIDs are typically not preferred in the later stages of pregnancy, like third trimester, it kind of becomes a category D. It can actually delay spontaneous labor, and we notice those adverse fetal effects. So again, prostaglandins are necessary to keep that ductus arteriosus open, to keep that fetal blood flow happening, like, you know, kind of mixing like it's supposed to. If we close that early with an NSAID, then you can see some issues with that because the kid's not breathing yet. They're not really able to handle that kind of circulation. So, but then afterwards, you can actually give it to them to close that up. So we'll do that occasionally. And then if we needed to keep it open, potentially, if they have like a congenital heart defect, we could give them what, do you think, to keep that open after they're born? We give them prostaglandins. We can actually give them a drug called alprostadil. Actually, keep that open. We'll mention that when we get to the peds section a little bit later on in this class. But just some things to kind of keep in mind that, you know, well, if they need prostaglandins, keep that open. Let's just give them synthetic prostaglandins, and they're good to go. So they do worry about, in some patients, they may have a predisposition. You may hear this like an NSAID allergy or an aspirin allergy, in which it actually will induce bronchospasm for those patients. I've kind of mentioned this before, I think, but do you guys remember the mechanism for how that works? So remember that pathway where we saw arachidonic acid being going down two different forks. You saw one of them going down the leukotriene pathway, and the other one going down the cyclooxygenase pathway. If I block the cyclooxygenase pathway, that arachidonic acid still needs somewhere to go, so it's going to get shunted over into the leukotriene pathway. And what do leukotrienes do within the lungs? They cause bronchoconstriction, right? That's why we give leukotriene receptor antagonists like montelukast for patients with asthma, right? So it makes sense that some patients are going to be more predisposed to this, especially if they're really sensitive to leukotrienes. So you may see that. So if someone says they have an aspirin allergy, it could be related back to their reactive airway disease or their asthma being induced or exacerbated by these NSAIDs. So kind of keep that in mind. And then most of them are going to be eliminated through the liver. So if they have hepatic impairment, you may see that the drug levels may stick around for a longer period of time. And then we obviously talked about the renal function issues. Remember that afferent arterial is going to be affected by prostaglandins. Usually prostaglandins are vasodilatory or constrictive. Usually vasodilatory, so I give an NSAID, and the patient's kind of dependent on that prostaglandin. That will cause a constriction, and then that GFR is going to go down acutely. So again, you can see kind of acute changes in their renal function related back to that. As soon as the NSAID's gone, prostaglandins can be made again, and then it'll dilate once more. Okay, so going into some specific agents, we'll kind of talk about any kind of unique properties to them. Obviously, aspirin we mentioned is going to be kind of in a league of its own a little bit, mainly due to some different therapeutic indications and different activity based on the fact that it's that irreversible inhibitor cyclooxygenase. So most people end up being on aspirin for what reason? Yeah, for cardioprotection, right? And what kind of dose are they receiving of that? Usually 81 milligrams for kind of just daily maintenance for cardioprotection. You can take a little bit higher than that, but what they find is even 81 milligrams, which they consider the baby dose of aspirin, you'll find that you get enough cyclooxygenase being affected by that you basically have, because you're taking it every single day, you get kind of a steady state level where basically all the cyclooxygenase needed to be affected is affected. And as you're producing new cyclooxygenase, that aspirin that's still around that you're taking every day can affect those new enzymes as well. So 81's fine. Usually if they're actually having like an acute, MI or they're having chest pain, then at what point you would give them how much? Yeah, you give them 325. So you give them like 4 baby aspirin, have them chew it up, and then that way they can kind of get a nice little bolus effect and get any COX enzymes that are not being affected yet with those platelets. So again, this is non-selective. So again, this means it's going to have those negative effects on the GI, that gastric barrier. So we'll talk about selectivity in some agents which are a little bit more selective and how those are going to be better for patients who have a history of GI ulcers related to NSAIDs. Now again, salicylates can be very, very dangerous from an overdose standpoint. So this is another one where you don't want patients just taking every time they have a pain or an ache or anything like that, they're just going to take a salicylate. You don't want them to do that because the fact that you can get a pretty nasty toxicity profile from this. This is another one of those ones where I say like a TCA is like an 11 on the sphincter scale, sphincter tone scale. Like these guys are probably like a 10. Like a patient can be very, very get very, very sick from these salicylates. And so earlier doses, lower doses, you can see, the antiplatelet effects. That's all well and good. But as you get to higher doses, around a gram, this is where you're going to see it being used more for antipyretic and analgesic properties. So like a rheumatoid arthritis patient, something like that, probably taking a little bit higher doses, probably somewhere between the 650 to a gram sort of range, right? And again, this dosing looks kind of similar to what we see like acetaminophen. So again, I'm not going to quiz you on doses specifically, but just to kind of get you familiar with it, usually people taking acetaminophen, usually 500 milligrams, 650, maybe up to a gram. So again, the dosing here is pretty similar, so it's good to know that when you're going to be recommending it to your patients. Anywho, you can still see some issues here like bleeding, the GI effects, some hypersensitivity, so that can occur there at these doses. Once you start to get above that, then you're going to see some of these kind of unique side effects related to aspirin. So you can get tinnitus that can happen here. Who says tinnitus? Yeah, I was saying that for a long time too, but I had an audiologist neighbor for a time, and I asked him, and he says tinnitus. And I was like, okay, I'm going to say tinnitus from now on. So I figured that you're the expert. At first I was like, what? And he said tinnitus. And I said, what? And then, anyway. But at even higher doses than that is where you start to see the aspirin will stimulate your respiratory drive, and you can actually see hyperventilation associated with that. So you end up getting this kind of respiratory alkalosis that occurs. I'm not going to go down the full toxicity pathway, but just know that if you see someone who is taking too much aspirin, like it's pretty obvious when you've seen a few of them, because you'll see them kind of hyperventilating, they'll be sweating, they'll be pretty red, and you'll see that you'll ask them like, how much aspirin have you taken today? And they'll be like, oh, I take a gram every time I have chest pain or something. I've had patients like that who just take way too much. And I mentioned this before, but what's kind of a unique dosage form that you'll see for aspirin that you see down here in the South? Yeah, you'll see like Goodies powders or BC powders. Those are very rapidly absorbed because they're already basically in a powder form. They just drop in some water and they'll take that. For whatever reason, a lot of people from the North have never heard of it before, but down here in the South, everyone takes their Goodies. And so it's important to ask about those sort of things, because they may not even think it's aspirin. They may just think, oh, I take my Goodies when I'm sore. They may not equate that with being aspirin, and you can run into some problems where they'll get aspirin in addition to that, and then they can see some of this toxicity. So obviously some people to watch out for, if they have bleeding disorders. Again, if you have a patient who's on warfarin or something like that, they can see increased risk for bruising and bleeding. With pregnancy, again, you may use this very occasionally, but for the most part, you kind of avoid NSAIDs as best you can for pregnant patients. And we mentioned kids should not be receiving aspirin. And why is that? Or about Ray's syndrome, right? So this is specifically kids who are kind of post-viral, so they have influenza or the chicken pox. A lot of kids are getting influenza right now. We had to open up a whole extra set of rooms. We had to like cordon off part of the radiology department at Nemours just for all the kids coming in with flu. So we're giving like Tamiflu out, like through the water fountains practically. But you're going to find that this is increasing that risk for Ray's syndrome that can occur here. Anyone remember what Ray's syndrome actually looks like? What it is? Yeah, they get this fatty liver encephalopathy. So, it's can be pretty much fatal, especially if you don't catch it kind of early. But this is why I just recommend, hey, avoid using aspirin in the kids, especially if they're less than 16. If they have, especially with post-viral, just kind of avoid it. Now, there's some instances where actually we'll use aspirin as a drug of choice for certain pediatric conditions. So, for instance, if you have like Kawasaki's disease, which I'm not going to talk about here, but that is one condition where aspirin is kind of a drug of choice. We'll see this a lot with some of our cardiac kids because we worry about their cardioprotection as well. So we use kind of baby doses for them to try to keep their platelets kind of inhibited. So there's places to use it in children, but just know on a routine basis, we don't recommend it. Does this happen with other NSAIDs? No, just going to be seen with aspirin specifically, right? So again, and some of the things you can see associated with Ray's syndrome actually looks like that viral illness they might have had. So if they have, that kind of that vomiting, maybe kind of lethargic, you can see hypoglycemia. Some of those things could be kind of related back and look very similar to the viral illness that, it's easy to see why you may not miss that sort of, or the parents might miss this kind of developing issue until it kind of gets too late and they're really kind of in dire straits. So again, just avoid it as best you can in those patients. Okay. Again, I'm not going to go through all the treatment. Just know that who to avoid aspirin in, if it came up on a test question, and who specifically that, the kids less than 16 post-viral, they're at high risk. Okay, There's also another salicylate. You might see diflunisal or Dolabid. This is used occasionally for osteo and rheumatoid arthritis. Good anti-inflammatory activity. Good, as an analgesic. And just know that the only kind of unique thing with this one, works very similar to salicylates like aspirin, but there is some risk for Stevens-Johnson syndrome. So watch out for that one if there's any new blisters or skin sloughing, anything like that. Okay. Next up, we're going to talk about the NSAIDs specifically, like the ones you kind of think of, like ibuprofen. We consider these, you can kind of classify them based on the chemical structure. So we'll talk about propionic acid derivatives, but just know them as kind of your kind of bread and butter sort of NSAIDs. Now, again, they are going to have less bleeding risk, as I mentioned, than the salicylates, right? But of course, this is all going to be seen relative to dose. So if I increase the dose high enough, you can certainly see more risk for that as that platelets get affected. But again, it's not going to be an irreversible effect. Definitely going to be reversible for these. Let's see. So a lot of the differences between these are going to be related back to their half-life. So again, don't memorize these numbers necessarily, but just know that some of these are going to be better for patients who have kind of chronic pain issues because you don't have to give them quite as often. So if you like watch Aleve commercials, what is their tagline? Just 2 a day, right? Like all day strong, whatever, all day long, whatever it happens to be. So again, that kind of goes back to the half-life of the drug. 14 hours, that'll kind of get you through most of the day if you just take one dose versus ibuprofen, relatively short half-life. How often do you have to take that? Yeah, maybe every 6 or every 8 hours, so you can take it pretty frequently in comparison to that. So maybe ibuprofen is better for more kind of short-term acute kind of pain issues, more chronic pain issues. You may see something like naproxen being recommended more. Again, these are available as your kind of over-the-counter, easily available to most patients. Then we get some other ones. Some of these are actually going to be available as intraocular products. You might see things like ketoprofen being used as an ocular product, used sometimes for like ocular surgery. We have other ones like oxyprosin, very, very long half-life. That one is called Daypro. That kind of makes sense on the brand name that it would last, all day basically. So you get very good pain control, very good kind of basal pain control throughout the day. And then obviously remember that we still have to deal with that kind of breakthrough pain as well. So kind of keep that in the back of your mind. All right. Other NSAIDs, indomethacin is one you may see. It's slowly reversible, but still reversible. So this is one we used to use very frequently as an IV agent to close the ductus arteriosus. And what's actually kind of interesting is that was kind of the go-to drug for PDA closure for a good long time. But then all of a sudden, the manufacturers for the IV ibuprofen said, well, we don't want to have any competition here. So they actually bought out the company that had the IV indomethacin, and then they stopped production of it. So you may not actually see that used all that too often, and then they charge more for their ibuprofen. So again, it's wily drug companies maybe not always having their patients in mind, but certainly their shareholders. Anyway, let's see. So anyway, they do have a pretty large incidence of side effects associated with this one. So not recommend all the time, but it's due to that kind of slowly reversible sort of effects here. So you see things like more like ulcers associated with it, that hematologic toxicity we've kind of mentioned already. And also, if you imagine, why do you think NSAIDs would decrease the efficacy of diuretics? Yeah, so it goes back to that prostaglandin synthesis and that GFR going down, remember? So if we decrease the amount of blood flow going into the glomerulus, less of it is available to get filtered, less of it's going to be able to be excreted as urine, right? So you can start to see some of these kind of interactions here where, say you have a patient with CHF, they're on, Lasix for that, try to get rid of some extra fluid, give them an NSAID because they stubbed their toe or something. You may see decreased efficacy of that, hold on to more fluid, go into a CHF exacerbation, and then back in the hospital. So kind of keep these interactions in mind. This is good for like education points. Remember, like, okay, what drugs to avoid, especially over-the-counter drugs, because they are so easy for patients to get a hold of and kind of self-medicate with. So again, education, very, very important here. But you'll see a lot of these kind of more potent ones we're going to be using, more recommended for short-term use because the toxicity is going to be a little bit more pronounced with them. You have ketorolac or Toradol. This one we use as kind of bread and butter sort of analgesic in the ER. So you'll see this used very, very frequently. It's good either as an IM medication or IV. And this one is definitely opioid sparing. So again, you can utilize lower doses of opioids in addition to this drug in order to deal with like postoperative pain or like pain in the ER, things like that. It's a very good drug from that standpoint. Less effective as an anti-inflammatory agent than some of the other ones, but very good as an analgesic. And so we'll give this very frequently. If you have a lot of patients who are like, yeah, I just really need some morphine. You're like, I got a really good drug for you. It's called Toradol. Most of the time they probably already heard of it, and they're like, no, I'm allergic to Toradol, I can't receive that. But this is a good one to give them if you don't want to give opioids, because it is a very good analgesic. You can still take care of your patient, right? Now, it is so potent that you do worry about it has this black box warning for some of the GI effects. So we actually limit use to no more than 5 days. So this is kind of a unique thing for the NSAIDs. Most NSAIDs you can use pretty much every day, no problems. However, this one, no more than 5 days because you increase that risk for GI toxicity. This is another thing where like electronic medical record systems can help us out a lot with it, because it actually will automatically build in stop dates for drugs like Toradol. If you don't want to give them more than 5 days, it'll automatically have a stop date of 5 days from whenever you actually write the order. So these are some things that the computers can help us out from a drug safety standpoint, but you may need to remember if you're actually if you're going to be prescribing it by hand or recommending it to a patient, right? We have tolmetin. This one you may see used occasionally. It's one of the oral ones, probably more potent than aspirin, but again, you're going to see a lot of these side effects associated with it. So not used super commonly, but maybe kind of a backup instead if they've kind of something like ibuprofen or naproxen's not really working for them. This one's an okay backup, but more toxicity. I have piroxicam. So this one is going to be pretty much equipotent to aspirin and naproxen, but it's kind of a little bit longer duration of action. So it's nice because, again, they don't have to take it quite as often as something like an ibuprofen. Fewer GI side effects here, but less chance for ulcers and things, but you still get some mild GI upset, but a little bit better than some of the other agents here. And then meloxicam. So this one's going to be getting into more selective agents. So we mentioned you can't use a completely selective agent for COX-2 because we mentioned what happens when that occurs. We're talking about Vioxx yesterday. I mentioned you actually see increased cardiovascular death, right, associated with just inhibiting cyclooxygenase 2. However, selectivity is going to be kind of on a spectrum. So you can have things that are somewhat selective for COX-2, and you still get better efficacy from not better efficacy from a pain standpoint, but you get a better safety profile from the GI standpoint. So meloxicam is a good one. Long duration of action, usually used 1 time a day, but it has a 10-fold selectivity for the COX-2. So patients who have to receive NSAIDs chronically, rheumatoid arthritis, osteoarthritis, this is good because it's able to help to kind of spare the stomach a little bit if they're at risk for developing this ulcer. So meloxicam is a really good one from that standpoint. Anyone know any other selective COX-2 selective? Yeah, Celebrex is going to be the other big one we'll talk about in a second. That one's even more selective than meloxicam is, so that's even kind of further on the spectrum, better for even more kind of high-risk GI patients. So nabumetone is another one. It's a prodrug, actually, that has to get activated within the liver. Has some COX-2 selectivity, so this one's good from a GI standpoint as well. Diclofenac, we mentioned this one being utilized for a topical use. This one's good to apply, locally to the joints, especially for a kind of limited number of joints being affected by, osteoarthritis or rheumatoid arthritis. This one also has oral options that are available as well. Again, has some COX-2 selectivity, so good from the stomach standpoint, right? Okay, so we mentioned that COX-2 inhibitors are going to have pretty much equal efficacy to your non-selective NSAIDs, right? But the main benefit is sparing the stomach. However, there is those concerns for CV safety, and the reason for that is because we mentioned that COX-2 is the inducible form of cyclooxygenase. However, it's really important for certain things like causing angiogenesis and regulating the vasodilatory sort of actions. And so they actually found that when you gave a pure COX-2 selective agent, you've had increased risk of cardiovascular death. So they actually had to pull those off of the market. Now the question is, how come they didn't find that when they were doing like clinical trials? What do you think? So how many people do we do trials in for like stage 3 trials? Like millions? Usually no, it's usually like in the thousands, right? So this is something that was only found when you were giving the drug to millions of people, because when Vioxx came out, it was like a blockbuster drug. It was like everyone was prescribing it. All the drug companies were saying this is the greatest thing ever. Please give this to everyone, and docs were doing it. And what you found was that when you gave it to millions of people, you're able to see these very statistically small differences, this increase in risk, and because of that, the risk was big enough. They said, well, we don't want to give it to anyone. Let's just go ahead and take it off the market completely. So nowadays we have things that are somewhat selective for COX-2, but not solely selective for COX-2. So that's where you have things like your meloxicam, like you have your Celebrex, things like that. So rofecoxib was Vioxx. That was the one that got first pulled off, and there's another one as well, that's valdecoxib. Now, however, when they looked at people receiving Celebrex for a good long period of time, because it has less selectivity, specifically for just COX-2, has some COX-1 activity, they actually found that the data tends to be pretty neutral. So again, if I had a patient with like a really high-risk cardiac history, I might avoid using Celebrex, but for most other patients, it's going to be relatively safe for them, especially if they have a history of GI ulcers related back to NSAID use. Okay, so anyway, just kind of talking about these specific ones. Celebrex is the only one really available on the market anymore. Totalac, I don't see too often. This one is available, but actually I've only ever seen it being used in animals. It's the only time I've ever filled it. I saw getting little doggy NSAIDs. Those big puppers, they get sore joints after a while and they get old and arthritic, so it's a good drug for them to help with their pain management. Okay, so again, looking at the selectivity comparisons, just know that celecoxib is much less selective for COX-2, and so that's why we still have it on the market. Why it's still a pretty good drug to use for those high-risk kind of GI patients. Okay. Again, they still have the same side effect profile for the most part as the other NSAIDs. It just mitigates the GI risk. That's really the big thing we're seeing differences in. Okay, so any questions on the NSAIDs? All right, so just for your sakes, so a really good IV NSAID you can utilize that I talked about. Yeah, Toradol is going to be your kind of go-to. Your ketorolac, it's a good IM IV agent. I don't think anything else. It's a big one you'll use probably most frequently from a parenteral standpoint. Again, if you work like in the NICU, you may see IV ibuprofen used occasionally for those PDAs. But then orally, all those other agents are available orally for the most part. If you need a topical NSAID, you would use diclofenac or Voltaren. So it's good to kind of start thinking about some of these different dosage forms which you have available to you. Okay. So I won't test you specifically on which dosage form, is Toradol available, IV, IMPR? I'm not going to ask you that specifically, but I'm trying to get you guys at least kind of acclimated to thinking about it now, because these are drugs you're going to run into pretty commonly. So just kind of, you can make notes of it. I probably didn't put it on here, but I'll make mention of it as we go along. Anyone know what plant that is? It's the poppy, yeah. It's actually where we get, what type of drugs? What drugs specifically? So we get heroin? Yeah, we get heroin from that. What else? Morphine, good. Anything else? Codeine is actually another drug that's very similar to both morphine and heroin. So we actually get, we'll call those our natural opioids. You're going to find that we have drugs that are considered natural opioids, and we're going to have ones that get a little bit more semi-synthetic. They kind of look like these kind of natural opioids, and they get some that are fully synthetic. And that'll be important when we talk about allergies. So kind of keep that in mind, that we have some that are coming straight from this poppy plant. However, we're going to find some that are fully synthetic and will interact with these receptors, which we'll talk about in a second here. However, so how do the opioids work? They mainly are going to be affecting, at least for our analgesic purposes and from a side effect standpoint, mainly we're going to see the mu opioid receptor being affected here. Okay, you may see some newer nomenclature referring to it as like OP1, but it's, the common name a lot of people know is the mu opioid receptor. Okay, there's also a kappa and a delta receptor. I'm not going to get into big detail on those. They have their own host of different properties to them and different effects that they confer. We'll mainly focus just on the mu receptor today. Okay. These are going to be good agents for moderate to severe pain. Again, if I go and I stub my toe or I get a paper cut, I probably don't need morphine for that. Acetaminophen is going to be just fine, right? So this is going to be for more kind of hardcore pain issues these patients may experience. So basically, how these are going to be working is, again, imagine you're having pain occurring, say, someone, dropped a weight on your hand or something like that. The acute pain issues happening here, you're getting inflammation happening. This is where a lot of our NSAIDs can be very useful to help, inhibit the cyclooxygenase that's starting to be induced there, right? We talked about things like local anesthetics that can help to deaden the nerves there to help prevent that pain signal from being transmitted. But the mu opioid receptors, primarily, we're going to see effect here, both in the spinal cord and up into the actual CNS itself. And this is primarily what we're going to see is this blunting of these pain responses they're having here. And again, I've never been, I've not used a ton of opioids in my lifetime. I think I was on Darvocet for a short period of time after I had my wisdom teeth taken out. But unfortunately, my use other than that is very limited. I guess maybe fortunately, probably if I never had to use them, right? However, the way that someone described it to me is that you still know you have pain. The pain's there. You just don't really care about it. You're not really fazed by it, right? Versus something like an actual anesthetic, which deadens the whole nerve signal completely, right? So this is just really kind of blunting the response there and having it so the patient is really not being that kind of distressed by it. So I'll have to blunt it, make it much more tolerable. So I mentioned the mu receptor here is going to be affecting mainly those neurons. The primary mechanism here is in this dorsal spinal cord, and you're also going to find some receptors up in the brain, but this is where you're going to see the primary analgesia response. This is also where you're going to get the euphoria, right, because this will have some indirect effects on those dopamine pathways, which is where we see what manifestation? Those dopamine reward pathways. What do you get when you activate that? You get the dopamine squirts, which causes Yeah, the reward pathway, which just means like, oh man, I really like that. What should I do? I should do it again. Yeah, so you see addiction, right? That's where you get dependence and addiction developing from that. So again, those are due to some of those mu effects up in the CNS as well. And so, so we get the analgesia, we get the euphoria, which is why these are controlled substances. And then the other big thing we watch out for is going to be this respiratory depression, right? So if a patient overdoses on an opioid, the thing that's going to kill them is going to be this respiratory depression. Okay, this is a big thing we worry about. Then we have the cap on the delta. You know, some of them can have different properties and actually get some analgesia from them, but we're not going to really focus on these too much. The mu receptor is the primary one I want to focus on for today. So you're going to find that when we talk about differences between opioids, and there's quite a plethora of agents that are available, it's important to be at least familiar with the majority of them, because either you're going to use them in the surgery setting, you're going to have patients that are on these for opioid addiction, you're going to have all kinds of different use cases for this, and so it's important to have at least a familiarity with these drugs. Some of the differences between them are going to include things like the binding affinity, how tightly the drugs bind to the actual mu receptors themselves. Some bind not so tight, some bind very, very tightly. What sort of clinical implication do you think that will have? Maybe on the dose. Maybe if they stick around for long, you don't need as big of a dose. But if someone takes too many opioids and we see them respiratory depressed, how do we think we're going to fix that? Yeah, so we mentioned Narcan before. You have to kick the drug off the receptor. So if I have a drug that's really tightly bound to that receptor, guess what? It's not going to want to come off very easily. So you run into some clinical issues with that where you need really big doses of a reversal agent to fix that. The other thing you're going to run into is going to be whether the drug is a full agonist or it's partial agonist. There's also some that have kind of mixed activities. We're not going to focus on this, but then we also talk about the antagonist, and the antagonist is going to be our antidote. It's going to be our naloxone that we mentioned before. We'll talk more about that in detail. But and so there are big differences here. And I probably mentioned the story before, but I didn't mention the lady that overdosed on buprenorphine or Suboxone. So you think someone who's overdosed on an opioid, what do they look like? Very sedate, pretty near comatose. Respiratory rates really is pretty low respiratory rate. So they're expecting that when you hear someone overdosed on buprenorphine. Buprenorphine, as we'll talk about a little bit later, is a partial agonist. And so we had this lady who came in, EMS calls in, hey, it's buprenorphine overdose, and so okay, we know what to expect. Lady comes in, kicking, screaming, biting, yelling at everyone. Was incontinent of stool, as we just see as a thing that can happen. And we're like, what the heck's going on here? Like, what's happening with this lady? And it turns out she's actually normally on a full agonist most of the time, but then when she took buprenorphine, a partial agonist that binds more tightly to the receptor, it kicked all of her, and she like methadone, it's her drug of choice, kicked all the methadone off the receptor, and now all of a sudden she put herself into what? Withdrawal, right? So we talked about withdrawal being an important thing with things like benzodiazepines and ethanol. You see withdrawal phenomena here as well, and so due to that physical dependence that happens. And we'll get into more detail on all these, but just know that it's important to understand, is it a partial agonist, a full agonist, because that'll give you some hints when you try to you see some of these interactions that happen here. Anyway, but for the most part, full agonists are going to be most commonly used. That's your heroines, your morphines, your codeines. These are all the most common ones you're going to see. Okay, so going into talking about addiction and chemical dependency, it's important to know kind of the different terminologies here and to try to make sure you're speaking accurately when discussing with like patients or other healthcare providers. So we'll talk about some of these different features here. So there's physical dependence, it's addiction, tolerance, and pseudo addiction. So when I say physical dependence, what do you think that means? So they may have cravings, but physical dependence. Yeah, so the body needs it around, right? So the body gets used to having that drug effect around. So you start to, again, homeostasis. The body's trying to keep things at a normal state. Your body's adapting to having that drug effect around. So when I take that away, that's when you start to see some of these withdrawal phenomena. So we mentioned how do people look when they're withdrawing from an opioid? They get diaphoretic. They get pale. They have seizures. They actually don't have seizures, right? It's one of the big differences between like a benzo withdrawal. Because we mentioned that benzo withdrawals can be potentially fatal, right? Because you can actually see seizures develop from that. However, the opioids, they're going to want to die. They're going to feel like they're going to die, but they're not going to die, right, from this. They get very shaky. They get very diaphoretic. They get potentially incontinent. We'll see one of the big side effects from opioids is what? Constipation, yeah. So if I take that drug effect away, all of a sudden I wake up their guts. They can have a code brown, as we call it. And typically their mood's not going to be great. Like they're going to be pretty pissed off. They're going to be pretty upset. And so they're going to want that drug back, right? Because they're physically dependent on having that drug effect around. Okay. Now is that addiction? I delineated it here, so probably not, right? So there's a difference there. So when I say addiction, what do you think we mean by that? We still need it physiologically. A lot of these patients will have physical dependence while they're on these medications, but addiction is kind of like a next step beyond that, right? Because what does addiction carry along with it? What kind of connotation? Yeah, a lot of it's psychological, so definitely a psychological component to it. The big thing here is they're using it continually despite negative consequences, right? So that's the big difference between physical dependence, where I need to have this drug around from a physical standpoint, because otherwise I'm going to go into withdrawals. But the addiction is going like, man, I really like the way that drug makes me feel. I'm not going to pay for groceries. I'm rather going to go get heroin instead, right? Or neglect my kids, or not be able to hold a stable job, or whatever happens to be. This continued use despite negative or if it's going to be really bad, if I end up in the hospital every time I go on a heroin bender, but I'm going to keep using it anyway. That's addiction, right? So continued use despite this negative consequences. That's kind of the delineation there. So someone can have physical dependence but not be addicted to it. However, everyone that's addicted most likely has that physical dependence, right? What's tolerance? I'm going to say that. Yeah, so you need more drug in order to do what? Yeah, to keep the same effect. You have to have more drug to keep the same effect. Because again, when I have these opioids come around, they're hammering these receptors. What do those receptors like to do in response to that? They usually will downregulate, right? Because they're being overstimulated, so they want to downregulate to kind of mitigate that response. And so you find that it is going to take more drug around as that homeostasis kind of tries to reinstate itself, drug in order to keep the same effect around. So that's why you may see someone start off with, say, 2 milligrams of morphine. Does them very well, but if they're on that every single day, you're going to find that effect's going to be less and less and less. So, is tolerance addiction? Definitely not, right? So if a patient says, hey man, that dose you were giving me, it worked well for a while, but now it's not really working anymore. I need a bigger dose. What might you think? You may think they're drug seeking. You may think they may have they're abusing these drugs. You may think they're addicted. However, in some cases, it could just be tolerance. It could just be not getting the same kind of analgesic effect that they had before. You mentioned it's really important to get good pain control underway, because that helps to stave off addiction. When patients don't have their pain well controlled and they start to have to self-medicate, that's when addiction is going to be much more likely. So again, keep tolerance in mind. And then we'll talk about pseudo addiction here in a minute. Anyone know what pseudo addiction is? So it's like kind of addiction. It's not really addiction, but we'll talk about that in just a second. So again, physical dependence, this is where you're having this kind of this neurophysiologic phenomenon, right? So you have that, the body's getting used to having that drug around. It's going to need to have that drug around in order to stave off these withdrawals. So again, a lot of nausea, vomiting, sweating, dysphoria, definitely not fatal. You generally do not have seizures related back to opioid withdrawal. Relatively, again, they're going to not feel very comfortable. No one likes to go cold turkey off this stuff. However, it's not going to be fatal for them, right? It's a frequent occurrence. We expect it to happen. If you're on opioids for a chronic period of time, it's going to happen. Now, if I get 5 days worth of Percocet after I have my wisdom teeth taken out, is that likely to cause physical dependence? Unlikely, right? This is going to be for more chronic patients who are taking these drugs for days, weeks, months, or more like months to years, essentially. However, not necessarily correlated with addiction, right? So you can have someone who has got their pain very well controlled. Say for instance, they had some sort of trauma, some sort of accident where they had these chronic, back pain issues. They're on these drugs for years in order to keep their pain under control. However, if you take that drug away, they're certainly going to go into withdrawal, but they're not addicted to it, right? They're just taking it in order to help manage their chronic pain issues. Okay, so definitely not necessarily correlated with those two. Addiction that we mentioned, usually that kind of impaired control drug use. You have kind of this compulsion to use a drug despite that harms, where you get all of those cravings and stuff. Now again, withdrawing due to physical dependence can appear like cravings, right? So you say, I need that drug around because otherwise I'm going to go into withdrawals. It may look a lot like addiction, but again, try to make sure you keep those two delineated in your mind. Tolerance we mentioned, this is where you're going to need more drug in order to keep the same effect around. Unfortunately, though, do you develop tolerance to the adverse effects of the drugs? Not really, right? So again, you can see this where patients are going to require escalating doses of opioids in order to keep their pain under control, but things like the constipation is just going to get worse and worse and worse, right? Opioid-related constipation is one of the worst side effects a lot of these patients will tell you about, because again, not being able to poop is a pretty big hit on your quality of life, right? You ever get stopped up, you're pretty cranky, you don't feel good. A lot of people need to go to the bathroom. Never underestimate the value of a good poop, okay? My wife can tell you that, working from a pain management standpoint, doing a lot of these hospice patients and end-of-life patients, you'll find that, especially like some of them that were like really non-communicative, they'd be on all these opioids and you know, their heart rate's still up, their blood pressure's still up. You just tell they're uncomfortable, and you're like, what the heck's going on? I got them on all these opioids. Their pain should be under control. And then you give them a really good bowel regimen, clean them out, and all of a sudden everything goes back to normal, right? You're like, okay, that's what it was, right? They had all this abdominal pain, all this backed up feces they need to get rid of, right? So again, we'll see constipation is going to be a big issue with this. Anyway, now you can have pseudotolerance, which is kind of where the disease state is changing, not necessarily the patient's response to the drug. So for instance, if the injury gets worse, or if something happens where certain activities are now aggravating it more frequently, you may find that the original dose that was good for their level of pain is not adequate to meet their new level of pain. So that's what another term we'll see called pseudotolerance. And then pseudo addiction, again, this is oftentimes kind of associated with kind of drug-seeking behavior. Oftentimes, this is related back to under treatment, right? So if you never actually get their pain under control in the first place, and we mentioned a lot of healthcare providers, do we like to just hand out opioids like crazy nowadays? No, we're worried about legal persecution. We're worried about getting people addicted. A lot of people are very, very hesitant to give out opioids like especially compared to what it was, several years ago. So nowadays, a lot of patients may not get their pain adequately met, and they may look like they're seeking drugs when actually their pain was never appropriately treated in the first place. Again, not to be confused with addiction. Again, they're not using it despite harm. It's just they never got their pain managed appropriately. Okay, so again, one of the big things you're going to see with addiction, trying to delineate between appropriate use versus addiction, the addicts typically lose function, right? They're typically, you find that they can't keep a job anymore, or they are not able to feed themselves very well because they are spending their money on other things, right? Typically, non-addicted individuals typically gain function when they're on these medications because they're able to manage that pain and be able to regain some degree of functionality there. So that's one way to kind of tell the difference. You're going to find that the incidence of addiction varies pretty greatly. Depends on the patient population, depends on what type of pain you're dealing with. It can range pretty widely. And is it easy to look at a person and tell whether they're addicted and drug seeking or they have legitimate complaints? No, because again, people who are drug seeking, guess what? They're pretty good at it, right? They're pretty good actors, and they can fake a lot of things, especially things that are very difficult to rule out in a lot of cases. I mentioned like someone faking kidney stones and pricking their finger to get blood into the urinalysis. Like they'll kind of lie, cheat, and steal to get lots of medications whenever they can. So anyway, those are good patients to say, hey, I got a good drug for you called normazoline. Give you a liter of it right now. Give a big dose. Run it in, you're going to feel great, right? It only works once though. They get used to it. They get pretty savvy to that. Anyway, have you guys heard of Ephors? I encourage everyone here to sign up for Ephors when they get a license. This is a very good website, and actually this is a prescription drug monitoring program specifically for Florida. Every state has to have their own kind of system here, and this one specifically is for Florida for looking at controlled substance utilization. Florida's kind of backwards in a lot of ways, like, you guys being able to even prescribe opioids, I think we're one of the last 2 states to be able to do that. Does that sound right? We're pretty late to the game from that standpoint, but we're also late on this sort of thing. We actually, the state government did not want to fund having a program like this, so this is actually kind of a privately funded sort of venture, but it's very good, open to all healthcare providers, pharmacists, PAs, docs, anyone can sign up onto this, and you can actually look up your patient to see where they have filled their prescription opioids or any narcotic substance within a given period of time, right? So again, this is not something that you have to send information out to this program for, but all the pharmacies automatically send this information out. So a good example use case of this was not too recently, and I probably mentioned the story already, but going back to like faking kidney stones, we had it's rare that you get adult patients in a peds ER, right? But we sometimes never see that. It's like, okay, someone had probably chest pain or something up on the floor and they're coming down. It's usually a visitor, but we had this parent who was there, and they were complaining of kidney stones. And I was looking at the chart. I was like, that's kind of odd. So they're giving her Dilaudid, which is an opioid we'll talk about in a few minutes here, before they get her stabilized and then transferred out to an adult ER, right? It's our typical process. And so I was seeing that, I was like, man, she was here for the same thing a couple days ago. Like, what the heck's going on here, right? And so I said, well, let me look her up in Ephors and see what's going on here. Okay, so I look her up in Ephors, and it turns out she had like 10 different addresses. That was all there for the same name. And it filled just all over the state, all kinds of different prescriptions, Percocet, Dilaudid, all kinds of stuff, and all within like the past month. Very odd usage pattern. So I went to the peds ER doc, and I was like, hey, look at this. And he's like, oh, she seemed like she really had pain. I thought it was legitimate. And I was like, well, they're pretty good actors. And he's like, well, I'm not giving her anything else anymore. So she never showed up again. But it's one of those things where it can be very useful, and you can take this printouts and you can say, hey, can you explain this? Can you say why in the world you're feeling all this stuff? And it kind of shuts them up pretty quick if they're drug seeking sort of patients, right? So it's a very useful tool. I've used it for other cases where if I have like an overdose patient who is not able to communicate, they're intubated or what have you, or their mental status is such they can't really communicate, and I need to know what drugs they may be on. I can get an idea of what, because a lot of them do fill opioids or other narcotics, I can get an idea of what pharmacies they actually fill it at, and I can call that CVS or that Walgreens and actually get information. Okay, here's all the other drugs they're on, and that can clue me into what type of toxicities I could be dealing with, right? So, if they have a beta blocker or a calcium channel blocker on board, I can kind of figure that out. Yes, ma'am. Yeah, so this only monitors controlled substances, right? So we don't have some states will have programs that will monitor for basically all prescriptions that are filled, but this is only for controlled substances. So it's one limitation, but still very useful, especially if you suspect someone being, and that can help you because if you have someone you're like, they might be pain seeking, maybe drug seeking, and put them in and they haven't filled anything, then that may lead you to think, well, maybe their actual pain is legitimate. Maybe I'm more likely to give them something, right? So it's a good program. I encourage all of you guys to sign up for it when you get out. Okay, so any questions from the first half? Are you guys all appropriately scared of using opioids? Don't be scared. They're not that scary. Just don't take too many of them, or have your patients take too many of them. They're very good drugs. We talk about this because the addiction issue is such a big deal, such a huge cost in terms of human life and resources. But don't be too scared of them. Use them when appropriate, as we'll see, and you get to the individual agents. But going back to federal scheduling of narcotics, you guys remember what a C1 substance means? No medical use. Highly likely to cause addiction, highly high probability for abuse, high potential for abuse. What's an example of a C1? Marijuana is still federally a Schedule 1 substance, even though we're decriminalizing it across the country. Not here in Florida yet, but we can use medical marijuana, which we'll talk about today, if I get to it, hopefully. Any other Schedule 1 substances you can think of? Cocaine actually is not a Schedule 1 substance. Cocaine is a Schedule 2. You can actually use it for some ENT surgeries. But yeah, that's Schedule 2 actually. We used to carry some cocaine over at Nemours. We don't anymore because no one ever used it. Our ENT docs were like, yeah, we use it all the time, and they never used it, so we just outdated it. So had to get rid of our cocaine. Very sad. Any other C1? Heroin is actually a C1. Although it used to be given in a lot of like old-timey products. Like Bayer, the manufacturer of aspirin, used to give out heroin on some of their stuff. Like, I really wish I could have practiced pharmacy back in the day because there's all kinds of crazy stuff that we're just not allowed to do anymore. Anywho, how about Schedule 2 substances? What does that mean? Still high likelihood of abuse, right? There is a medical application for it, right? So cocaine, we have a medical application for it. However, like right now, the federal group still says there's no medical use for marijuana, even though we know there's some evidence to say that that is not the case. And then how addictive is marijuana? Say versus something like heroin. Not really, right? So again, not all of these delineations are going to be fueled completely by logic or reason. A lot of this goes back to certain like kind of political. There's documentaries out there you can watch. I'm not going to get into it here, but lots of interesting kind of political changes that have been done to things like marijuana and other drugs that make them this way. Now, one of the big problems we ran into for a lot of these when like K2 and Spice and those synthetic cannabinoids came out was a big problem because you could buy them basically anywhere. You can go in the gas station, you can buy them online because they were actually non-controlled substances because it was a new chemical entity, right? These are like research chemicals that just were not federally regulated. And so then the government has to come in and say, okay, we're just going to put all these drugs onto a Schedule 1 list. It may actually find that certain states will schedule drugs differently depending on certain situations. So you may find that the Florida Schedule 1 list is a little different than say like the Texas one, and like for instance certain drugs may get a Schedule 4 marking at the Florida level, then it might be a non-controlled substance elsewhere. So for instance a drug called carisoprodol or Soma. Anyone ever heard of Soma? You may hear the Soma coma. Some people take too much Soma and they get very, very comatose. That one is actually Schedule 4 substance here in Florida, but maybe unscheduled in other states. And so there may be some differences there that are on the state level versus on the federal level. Again, which one do you kind of go with from a from a strictness standpoint? Which one should you follow? Typically, whichever one is more strict, right? So you typically go with whatever law, Florida law is more strict, you go with that one versus. Now, what's interesting is because we're decriminalizing marijuana in a lot of places, that people are just kind of like, well, yeah, federally it's still Schedule 1, but no one's going to come get us, so whatever, right? Marijuana is an interesting topic, but again, not really in our purview right this second. Anywho. Continuing on, let's talk about codeine. Codeine is a very common, kind of older drug. You normally would find this in combination with acetaminophen. So your Tylenol number 3 is what that's referring to. I think it has 30 milligrams of codeine and like 300 milligrams of acetaminophen. I guess Tylenol 1 and 2 just were not good. But Tylenol 3, that was the ticket, right? Now, codeine is interesting because in and of itself, it doesn't really have good analgesic properties. It actually has to get converted into another drug. So you can kind of consider it sort of a prodrug. Anyone know what it gets converted into? Morphine. Yeah, actually, codeine gets turned into morphine via CYP2B6, or 2D6, I'm sorry, 2D6 right here. And so what you can actually find, some people respond really well to Tylenol number 3 because they have a very active CYP2D6, and they can convert a lot of it over into morphine. Some people have kind of low activity of CYP2D6, and they don't convert a lot of it, and they don't really respond well to the drug because they're not getting as much morphine out of it. And so that's actually been leading to a lot of interpatient variability. And I mentioned as well, actually some kids were dying from this because they were having these kids with obstructive sleep apnea. They're going in, getting a TNA, and coming out, and they're getting put on codeine containing products. And some of them that were very rapid metabolizers would get turn a lot of that into morphine. And then guess what? They're already kind of swollen up anyway from surgery. They already had OSA to begin with. Having that respiratory depression on top of that, they were basically just dying in their sleep. And so we realized that because of that risk, they're actually not using codeine nearly as much as we used to. We took it off the formulary at Nemours. A lot of peds places just won't recommend it anymore. You may still see it used outside of, maybe in the adult world occasionally, but it's really kind of falling out of favor due to this kind of interpatient variability due to CYP2D6. But much less potent than morphine, and it's pretty wimpy from an opioid standpoint, so more mild to moderate sort of pain. Again, not used super commonly anymore. And again, depending on the formulation, maybe like a C5 or C3. And again, I'm not going to ask you specifically like which is this drug a C1, 2, 3, or 4? Like, that's not a very good test question. But just know that depending on formulation, you may find different schedules on this. You remember the difference between like prescribing for like a C2 versus like a C3? Yeah, you can't do refills on a C2. You know how many refills you can do on a C3, 4 or 5? You do up to 6 months worth, right? So you can write for that initial fill and then have like 5 additional refills. 6 months is the max you can do on those. Okay, so again, just remember some of those regulations there. So again, we generally avoid this. You may find patients with like Middle Eastern descent or North African descent. They tend to have higher activity of their CYP2D6, and those are the patients who are more likely to have those bad outcomes after surgery. So again, not used super commonly. We'll talk about adverse effects here in just a little bit as well. But next we have morphine. Morphine is good. It has several dosage forms that are available. We use this one very commonly in the IV route. This one is also available orally as well. You have some forms that are immediate release. So you see that morphine IR that is available as immediate release product. There's MS Contin. Usually if you see Contin on the name there for whatever reason, I guess maybe for continuous, but it's an extended release product. So MS Contin would be the extended release form of morphine to kind of provide better kind of all day sort of coverage. And then you may have additional morphine for like kind of breakthrough, like immediate release morphine. But so this one is kind of interesting because it undergoes a lot of hepatic metabolism, and what you find is that these metabolites actually get eliminated through the kidneys, and so we run into issues with patients with poor renal function, but they actually hold on to some of these metabolites, specifically this morphine 6-glucuronide. And who might you think might have poor kidney function? Elderly patients. We're going to find certain opioids you don't want to use in elderly patients, and this is one you want to be careful of with poor renal function. They actually will accumulate that metabolite, and again, it has good analgesic properties, even better than morphine itself, and so it is able to cause a lot of CNS depression, respiratory depression in those patients. So it's not a good one to use for them. So again, keep in mind whether it has metabolites or not, because that will inform some of these problems in certain patient groups. Now, another thing you'll see with morphine is there's a lot of histamine release associated with it. So this is causes a lot of side effects. Why a lot of people don't respond well to morphine is not because it doesn't deal with their pain very well. It's more this pruritus that happens. They get potentially very big doses given too quickly. You can see hypotension that can develop due to this histamine effect. They can get very flushed and very kind of itchy. It's not like a true allergic reaction, and you can pre-treat. You can treat through it. And what would we use to treat that? Yeah, use Benadryl. You can use antihistamine to treat the histamine release, right? That kind of makes sense. So either you can pre-treat with it if the patient does well with morphine with that. or you could switch to a different agent that does not have as much that histamine release. Now remember, what's a big side effect with using antihistamines, especially the first generations? Sedation, right? So now all of a sudden you're giving morphine, which is sedating, and you're giving an antihistamine, which is sedating. You can see some synergistic problems there, right? So again, sometimes the best answer is not to add more drugs, but to switch over to a different one altogether. Okay. Next we have hydrocodone, which is found in some brand name products like Norco or Lortab. There's actually very rare that you ever find hydrocodone by itself, but there's actually a dosage form called Zohydro, extended release, which I think has up to like 80 milligrams of hydrocodone, which is like just a god awful amount of hydrocodone. And I fear anyone who breaks that extended release preparation to try to abuse it. But anywho, generally you're going to find this in combination with acetaminophen. And like I said, this is one of the most widely prescribed medications. If you look at a top 100 drug list, hydrocodone and acetaminophen is usually at the top of the list because it's very frequently prescribed for all sorts of kind of acute pain issues. So this one itself actually gets converted into hydromorphone, which has another brand name of Dilaudid. We'll talk about that one in a minute here. But you're going to find that, again, there is some interpatient variability because if you have poor CYP2D6, you may not get a ton of efficacy out of hydrocodone. So not everyone's going to respond super well to this drug in particular. This is going to be less clinically relevant than with the codeine issue because, again, codeine itself has really kind of poor analgesic activity, but when it's morphine, it has a good activity. Here, the hydrocodone itself is still active. You just may find that patients don't respond as well to it as they may to other drugs. Okay. Again, it used to be a C3 for a very long period of time, so you could use this more easily for patients with chronic pain issues because you can give them refills and things like that. However, now it's C2. They really kind of cracked down on it. It's much more difficult to acquire, all the regulations that go with that. So no refills on this one. A lot of places are refusing to fill beyond a certain number of days worth of the medication. So I think I can't remember CVS or Walgreens. I think it was CVS, but they came out with a new policy saying that for these kind of new scripts coming from ERs and stuff, they would only not fill more than 3 or 5 days. I don't remember the exact policy, but they're really putting a limit on how much they were filling. So even if you wrote for 100 tablets, for a 3-day period, which would be insane, they would be like, no, we're only going to give you say like 12 or 15, whatever it happens to be. So again, you're seeing a lot of places cracking down on overutilization of these. So anyway. And this one actually does have a liquid formulation as well, which is good for pediatric patients, especially like our post-op kids. A lot of ENT surgeries and things like that that are coming. They're getting discharged same day. They'll end up getting liquid hydrocodone acetaminophen, and they call it HiSet is the brand name for that one. But again, remember it has acetaminophen in it, so you have to factor in all the Tylenol they're getting throughout the day. So don't recommend they take Tylenol in addition to this. Usually I would recommend like an NSAID in addition to this. That way they're actually getting 3 analgesic drugs at that point. They're getting the opioid, acetaminophen, and the NSAID, and that way they can kind of cycle between them, and that way they get better kind of pain control. And so a lot of times what I'll see recommend is they'll do, like, say, take hydrocodone now, in 3 hours take ibuprofen, 3 hours maybe take the hydrocodone again, so they might do that for a few days in order to help kind of keep that pain under control, and that way they're kind of always getting some drug, and that way they kind of keep those levels high for them, right? Kind of make sense? Anyway, but most often you'll see it prescribed as a PRN as needed. Make sure whenever you're at PRN that you say for what. I see a lot of prescriptions will come by and just say, take this as needed. It's like, well, for what? Like, should they try something else first? And so we'll build in a lot of the stuff into our EMR. Say, okay, if they fail oral ibuprofen, then they can utilize this, right? That way it kind of gives the nursing a little bit better idea, like, okay, well, which one should I use first? Should I use it for a specific pain scale? That's all very important information to have in there. So, pain at a 4 to 7, take hydrocodone and acetaminophen, something like that. Next we have oxycodone. You can find oxycodone by itself, so either in an immediate release preparation or as extended release. Again, hydrocodone really only going to be orally available. Oxycodone as well, only orally available. I'll talk about the IV ones in just a second. Morphine definitely is available IV. Extended release preparations, OxyContin is a very popular drug to abuse. Like you said, Florida was one of the first stops on the OxyContin Express, as I mentioned. Because they'd find is that a lot of these preparations they would just crush them, or they would find some way to kind of break that extended release preparation and get a very big dose all at one time. They could either inject intravenously, or they could snort, or however they wanted to take it. So instead of getting 80 milligrams throughout the day, they would get all at one time to kind of deal with their addiction and or to abuse it for the kind of euphoric effects. In fact, this is one of the most common pill identifications that we would get at the Poison Center. People call up and like, hey, I found this pill on the ground and I need to know what it is. And I like to have a game. I'd play a little game with them. I'd be like, well, what do you think it is? And they'd be like, oxycodone. I'd be like, what milligram do you think it is? And they're like, 80. And I'm like, congratulations, it's an 80. They get very excited. I say, okay. But hey, we're doing our job, right? Actually, there are several websites you can go and actually do that. So I don't know why in the world they were having to call us in the first place. However, it's good for an epidemiologic standpoint. We can actually track things. So if we're seeing, a ton of, pill identification for oxycodone, like in one specific geologic area, that kind of gives us, kind of good clues on certain trends and things like that are happening, which is kind of cool. But anyway, not to go back to EpiBio, you guys have already had enough of that for one lifetime, right? Ooh, that sigh of relief, my goodness. Anyway. This one itself does have a little bit of that metabolism over to oxymorphone. This is actually another active analgesic that you may see some products for. But again, less clinically relevant than with the codeine. The codeine is really the big one to remember, that CYP2D6 metabolism issue there, right? And again, very commonly given with acetaminophen. That's where you get your Percocets. And this again is a C2. So again, very strict control on this, similar to the hydrocodone nowadays. Now, would it make sense for someone to be like on immediate release and extended release oxycodone at the same time? That one actually would make sense. You would normally think, why give multiple products of the same drug? But again, remember that little graph we were looking at. We were looking at pain throughout the day. Imagine they have kind of this baseline pain that's happening, these little spikes that happen here and there. And if you were taking your hydrocodone, or oxycodone in these cases, you'd want an extended release preparation that would be able to kind of manage them. Actually, so you get above the pain level kind of throughout the day, and then you'd have an immediate release that you can get for these little spikes here, right? Maybe I'll draw. Looks like a cat. No. Anywho, but basically you need the immediate release. I do something to entertain myself. So you need the immediate release to kind of help cover those little peaks there, where you have the extended release to kind of better throughout the day. So you may take like OxyContin twice daily, and then you would have an immediate release preparation taken, say, every 4 to 6 hours as needed for breakthrough pain. That's how you would write for that essentially. OxyContin is actually a really interesting one. You can look up some good news articles on that, because that's thought to be one of the main contributors to the opioid epidemic that we're in right now. And what's interesting is that OxyContin, when all the marketing was coming out about it, all the drug reps and stuff, they're saying it's twice daily drug. You only give it Q12 hours. But even though the studies were finding that patients were actually losing efficacy around the 8-hour mark, so really it needed to be a Q8-hour drug, but that didn't really help out the marketing, because they wanted to say, we got the only Q12-hour drug out there, only twice a day. It's great for compliance, but the data didn't really support that. And so by prescribing it Q12 hours, and patients are starting to have a wearing off effect at around 8 hours, what are they going to do? They have to self-medicate at that point, right? So either they'll take continue taking more immediate release doses than what they would actually need if they had taken the OxyContin Q8 rather than Q12. But so that's one of the kind of contributing thoughts there. So it's kind of interesting. There's lots of good articles out there you can read up on if you're interested. Anywho, another good drug. This is a good one that we have available as an IV product in addition to oral products. So this is called hydromorphone, or Dilaudid, or Dilaudid if you don't know how to say it correctly. I've had a few patients ask for Dilaudid, and I'm like, Dilaudid. Anyway, so this one is kind of interesting. There's a few kind of byproducts that can cause some issues. You can see some myoclonus to this hydromorphone 3-glucuronide, but you don't have the same kind of metabolite accumulation effects like you see with the morphine as you did in those elderly patients. So not a big deal with that, and relatively short half-life, and is associated with less pruritus than you see with morphine. So this is a really good one if you have a patient who does not respond well to morphine due to the histamine effects. You can give them hydromorphone instead, and that's going to be fine. I'll talk about allergy in a second here and talk about cross-reactivity between different opioids, but this is potentially one you can utilize for some of these morphine allergic patients. And you've seen a lot of growing use with this for lots of different cases, and we'll talk about patient-controlled analgesics in a little bit as well. This is a very common one we'll use with those PCA pumps, which I'll talk about. Anywho, and there's fentanyl. Fentanyl is kind of a little notorious nowadays. You're starting to find. Where have you guys heard about fentanyl at? Maybe with illicit drug use. Yeah, they're actually starting to mix this with heroin, and so this is actually kind of a big safety concern, because this drug is super potent. Say for instance, like with morphine, a good IV dose is say like 2 milligrams, right? So you can get some decent analgesia out of that. Anyone know how you dose fentanyl? Well, as far as like how much actual drug you're giving. micrograms, right? So this is like 1,000 times more potent than morphine is, right? So very, very potent drug. Just a little will do you pretty fine, right? So you can get, say 2 milligrams of morphine might be equal to, say, I don't know, maybe 40 or 50 micrograms of fentanyl, right? So again, does not take a whole lot. And so what's happening here is that people who are buying heroin, if they don't realize it's laced with fentanyl, they may take their normal dose of heroin, not realizing the super potent opioids in there, and all of a sudden they get much more respiratory depressed and CNS depressed than they would have otherwise, and then they die, right? So this is a big concern that we're seeing with a lot of law enforcement and stuff. They're seeing these patients who are just like, who take their normal amount, but they're just kind of out for the count essentially. So, anywho, this is a synthetic opioid, meaning that it is completely not structurally related whatsoever to morphine, right? So, like you think of the natural opioids like morphine, codeine, heroin, they all look very, very similar to one another. They have the semi-synthetic, which are like your hydrocodones and oxycodones. Fentanyl itself looks nothing like morphine. It's very, very synthetically derived. Looks nothing like that. And that's important from an allergy standpoint, as we'll see here in just a minute. Actually, not 1,000, but 100 times more potent than morphine. But fentanyl is a very good drug. We use this a lot in surgery. It has lots of different dosage forms that are available. IV, you do transdermal, so you're here Duragesic. That's a transdermal form of fentanyl. It's good for kind of long-term pain control. And then we'll have transmucosal. So this is actually the fentanyl lollipop, which I always thought was kind of interesting thing. Like, you want to keep drugs away from kids, but they see a lollipop, they might try to suck on that one for a while, and it would not go well for them. We also are actually using a lot of intranasal fentanyl as well. We use this a lot in the peds ER because, again, how easy is it to get an IV on a kid? Not just actual physically, it's hard because their veins are so small. But then if they're kind of anxious or they're in pain or whatever, they can be difficult to manage from that standpoint. So we can actually use intranasal fentanyl. It's a very common one. You have to modify your dose to be a little bit higher, but it's very easily absorbed through the nasal mucosa and very good pain control without the need for an IV. So that's one you may see used occasionally there. Again, very good use for acute pain issues. We may use long-acting forms though for the more chronic problems. So usually the transdermal form we'll give as a patch, and they can leave that on, I think, for like 3 days if memory serves, and they will leave that on. And then, again, remember whenever you take those patches off, do they still have drug on them? Yeah, be very careful. Make sure if they have like small kids in the house or animals, that they dispose of those patches where they cannot get access to them. Because if someone swallows that, there's still a ton of drug in there, and they get a lot of fentanyl in their system. So there's a couple of congeners. You guys heard of the term congener before? You know what that means? These are like chemical cousins. These are like drugs that are structurally very similar. They act very similar. They may have a little bit different profiles, but these are the congeners for fentanyl. So this is alfentanil, sufentanil, and remifentanil. And so my dad's a CRNA, and I don't know if you know this, but I might have got my sense of humor from him. So he always talked about fentanyl and the fentanyl siblings of Al, Remy, and Sue. That's just how he remembers them, and that's not how I remember them. Anywho. But these are very, very potent fentanyl derivatives, and they are usually in the surgical setting. So very, very potent, very small dosage you're giving, but they're very good for getting a patient under general anesthesia and kind of keeping them there. Now, the thing with allergies is that if you see someone with like a morphine allergy, you have to be careful which drugs you're going to give them, because if they have a true allergy, there is some cross-reactivity that happens. In general, you're pretty safe if you give a synthetic agent to someone who has a morphine allergy, because they structurally are different enough that there's really no cross-reactivity there. Some of the semi-synthetics, like hydrocodones, still share a little bit of structural similarity. The chances are low they'll have a cross-reactivity, but you're safest if you give something like fentanyl. Now, a lot of people may be reticent to give fentanyl because they're like, well, that's like a surgery drug. It doesn't have to be, right? It's all in the dose you're giving here. So I feel very comfortable. If someone has a true morphine allergy, I say, well, give them a dose of fentanyl. You'll find, we'll talk about conversions a little bit later on. But again, there's conversions for all these opioids to make sure you're getting the patient the right dose. And this is a very good drug to use for those allergic patients. So looking at the structures, again, I'm not going to have you reproduce these, but if you imagine heroin versus morphine, you can see how they look very similar. Fentanyl looks nothing like it. So again, you don't really have any antibodies that have been sensitized against these structures, so it's very safe to give in that case. And very few people really have allergies to drugs like fentanyl in the first place. I don't know if I've ever seen one. But certainly morphine is a lot more likely to have some allergies against it. Okay, who's heard of methadone? Where do we use methadone? Yeah, so usually people are opioid addicted. This is one of the main drugs we use for opioid addiction. So the question is like, why am I giving an opioid for someone who's opioid addicted? The taper, absolutely right. So it's like the same reason why you give nicotine to people who are, cigarette addicts, right? So we will have this taper built in with methadone because it has a very long half-life. So if they use heroin, if they use prescription opioids, whatever, it doesn't really matter. We can use methadone as a very long half-life sort of acting drug. It has a half-life greater than 50 hours. So that way you can actually give it to the patient. And you guys heard of methadone clinics? Basically what would happen is patients would go in, they would, as kind of direct observed therapy, they would go in, get their dose of methadone for the day. It would last them throughout the day, and they would basically take it on Monday, Tuesday, Wednesday, Thursday, Friday. So they have nice levels built up by Friday come, and then they would have basically the weekend where the clinic shut down. They would be able to get through, hopefully with their levels still pretty high, kind of tapering down by Monday. But then Monday morning, I'll tell you what, methadone clinic's a hop in place. Because as soon as they open the door, they're in, they want to get their stuff because they're starting to go into withdrawals. Right? That's the concern here. So the main thing with opioid addiction is you need to have ways to manage these withdrawal symptoms, and so this is one of the ways we do that, long-acting opioid. Now, do we only use it for opioid addiction? Actually, we're starting to use it for a lot of other purposes. So again, it's nice that it has a long half-life. We can actually use it for, you guys have heard of neonatal abstinence syndrome? You know what that is? That's basically where you have mothers who were abusing opioids during pregnancy, and the kids come out, and guess what? They're addicted just like the mom was. Basically, they have that physical dependence, I should say. And so we have to give them something to replace that. Otherwise, they get very, very fussy. They are very difficult from a feeding standpoint. Temperature regulation is kind of crazy. So you need to give them something to help manage that withdrawal. And so this is where we'll give methadone as a long-acting drug. So you'll see if you go to a NICU, you may see several kids who are on methadone tapers, where they'll be tapering off of this over the course of weeks to a month or so. So anyway, there's some other nice benefits to here, and you may see some patients being using methadone for chronic pain because, again, it's a good long-acting medication, similar to like an OxyContin, right? It has a long duration of action, so it's good for kind of those chronic pain issues. This is not a good acute pain med, right? Because again, even though it's immediate release, it's not really good for kind of getting those kind of acute spikes in pain, because otherwise the drug sticks around for long, and you really accumulate that levels pretty high. And then kind of some other things it can help with. Some people think this is good for neuropathic pain because it actually helps to reuptake or inhibit reuptake of norepinephrine and serotonin. So there's some additional benefits with methadone there as well. Let's see. So again, you're starting to see this a lot more being used for chronic pain issues, especially like chronic cancer pain, things like that. And as far as from a side effect standpoint, you want to be careful with QTC prolongation. This is another med that can do that. So this is kind of unique from the opioid standpoint of being one of the few ones that actually increase QTC intervals. So you want to watch out for that. Okay. And be very careful when you're converting patients from one drug to another, because there's a lot of different kind of ratios that are out there for conversions, and none of them are going to be perfect. So we'll talk about opioid conversions a little bit later on, but you got to be very careful with methadone. And it's one of those things where if a patient comes in and they're on methadone, like say they're going to be admitted to the hospital, if you ask them how much they drink, and say one drink, you always usually double how much they drink, right? When they tell you their methadone dose, usually half that, because you have a lot of patients who will say, oh yeah, I'm taking 40 milligrams of methadone a day, and they're actually on 20 because they're drug seeking. And so this is where something like Ephors can be very good, because you can actually find out how much they're really getting, or contact the methadone clinics they go to make sure you get an accurate number. My wife, working at ORMC, had a case where they have MedRec pharmacy technicians in the ER that will do the medication reconciliation, and they had a patient who told them, hey, I take this really big methadone dose. It was a high dose, but it wasn't anything insane. And then the pharmacist verified it. The provider who was admitting did the MedRec, said, yep, looks good, and they started the patient on that dose. Next morning they come in, he's respiratory rates like 6, and he's non-responsive, almost need to be intubated. So you got to be very careful with that. Make sure you're double checking on these doses to make sure you're dosing them appropriately. Okay, next up we have meperidine or Demerol. Some people like to refer to this as Demonol because it's very kind of nasty from a side effect standpoint. A lot of people don't like this drug very much, so we don't use it too often. This one you'll most often see in the surgical setting for one specific indication, but we used to use it more often for other things, but due to the toxicities, we don't like it anymore. Basically, we have a metabolite here that gets produced from meperidine called normeperidine, and if you have patients with renal dysfunction, they like to accumulate this metabolite, and you can see seizures develop in those patients. So because of that, they used to give Demerol to these elderly patients for their chronic pain issues, and they developed seizures kind of out of nowhere, and it was linked back to this normeperidine here. So we don't like to use it for them. Not a very good drug from that standpoint. And actually, there's some interactions here with monoamine oxidase inhibition as well. So you can actually see a tyramine reaction, similar to what you would see with your other monoamine oxidase inhibitors. They also developed a tolerance really quickly to it, so not very good. What we actually use it for nowadays is for rigors in the surgical setting. Anyone know what rigors are? Yeah, basically shivering that happens there. We, from an emergency medicine standpoint, we'll sometimes use this when we're doing therapeutic hypothermia. So someone has a cardiac arrest and we're trying to cool them down. We will sometimes give this to them as well, because again, when the body gets cold, what does it do to try to warm up? It shivers, right? So it actually is kind of antagonistic to the cooling we're trying to do. So we'll give them a Paradine to try to stop that, and then it will help them to keep cool for more predictably stay cool. This is another one, propoxamine. This one's actually removed from the market, but you may still see patients who have this kind of squirreled away somewhere. They might talk about them being on Darvocet, or Darvon's another name here. Usually if you see like a CET in one of these names, that means it has acetaminophen in it. So this is another one that commonly had a Tylenol in conjunction with it. This is another one we took off the market due to a seizure that could happen when you had renal dysfunction. And you also found that there's some cardiac conduction issues. And so this used to be used for a really long period of time, but really not found to be super useful. And so they removed that one from the market. But you still may see patients talk about it occasionally. Okay, this is kind of an up-and-coming sort of opioid. This is called buprenorphine, Suboxone, Subutex. This is a very long-acting agent. It also binds very, very tightly to the receptor, the mu receptors, but this one's only a partial agonist. So anyone know where we use buprenorphine for? What sort of indications? So think about this one kind of the same league with methadone. This one's used for opioid addiction. So this is an up-and-coming one for that, where because it only partially stimulates those receptors, it'll help to prevent withdrawal from occurring. However, it will not really giving that full euphoria type of effect as they would see with whatever their opioid du jour was, whether it be heroin or whatever it happened to be. So from that standpoint, it's thought to be very good for helping patients to kind of taper off of their opioids. A very long half-life, very similar to methadone, so that way it sticks around for a while, helps have that nice taper there. And this one has a lot of different options that are available from a dosing standpoint. There's sublingual preparations, there's transdermal ones, there's even implants they have available that will slowly release buprenorphine over the course of several months. Can be another option there. But and you may see a product called Suboxone. So Subutex itself is just buprenorphine by itself, but you have Suboxone, which actually has naloxone mixed in with it. We said naloxone. What's another name for that? It's Narcan, right? So what do we use that for? Yeah, use it for overdose. It helps to reverse, basically, we'll talk more about it in detail, but it helps to reverse an opioid overdose. And so why do you think we would mix these two together, buprenorphine plus naloxone, together in one product, besides the fact I have it on the slide? Yeah, so if you try to crush it up and try to inject it, you find that naloxone is not absorbed orally. You don't get any GI absorption. So if you take it normally, the GI tract, you really don't see any naloxone effect, right? However, if they try to inject it, you'd have naloxone would essentially put them into withdrawal, and so it's meant to deter that. So if they have a really bad high when they inject that, then they know that they probably won't do it again, essentially. Again, of dubious efficacy, but that is the idea. So if you ever see these drugs mixed with naloxone, that's usually what it is done for, especially oral medications, to avoid IV abuse. Make sense? Okay. So those are the main opioids you're going to come across probably in your career. Hopefully you have at least some familiarity with them now. Generally, you're going to find that when selecting an agent, you want to do it based on several things, like looking at their pain intensity, right? So again, if they have, they have an obviously displaced fracture, Tylenol number 3, oral is probably not going to be a good option for them, right? This is something they need, IV morphine, intranasal fentanyl, something like that. You need to use a little bit more kind of hardcore medications, depending on the type of pain you're dealing with. You also want to look at coexisting conditions, like look at other medications they might be on, because they help guide you into selecting an appropriate agent for them. And obviously economic factors, what can they actually pay for, what's covered by the insurances, etc. Remember, if they're having kind of persistent pain, you want to use a long-acting formulation in addition to something for breakthrough pain. Okay, so you have like an extended release preparation they'll use throughout the day, and that'll be scheduled every 8 hours or every 12 hours, and they'll have something that's going to be as needed for breakthrough pain. That would be how that's written there. And so you need to have both coverage, because otherwise, if they're only on a long-acting formulation, they have nothing for the breakthrough pain, they might try to self-medicate, and that's not going to be good if they're taking too much of that extended release preparation. The levels will get too high, get seen as depressed, it's not going to be good. Transdermal drugs are only good for long-acting effects. So we mentioned how quick is the onset for a transdermal drug? Is it quick or slow? slow, right? It takes time for the drug to disperse to the tissue to actually get into the bloodstream. So this is one of those things where you don't want to start a patient off on a Duragesic fentanyl patch and expect it to kick in immediately. It will not work like that. It needs at least 24 hours or so before it really starts to kind of get into the bloodstream. And so you'll see this on the inpatient side. If you're trying to convert someone, like say, from IV morphine over to a fentanyl patch, you'll find they'll actually will put the patch on, they'll leave it on for 12 or 24 hours with the other medication still going, and then they'll decrease that as the fentanyl starts to kick in. That way you kind of avoid any lapses in coverage there from a pain standpoint. That's one thing you might see. Be very careful with the fentanyl patch. This is kind of one thing to note. You do not want to put heat on that patch. It will actually stimulate further release of the drug, and there have been deaths associated with that. So for instance, you got like really bad back pain, slap a Duragesic patch on there, think I'm going to go to the hot tub and try to relax his muscles a little bit. Guess what? All the hot water is going to release all that fentanyl into the bloodstream. And guess what? You find him dead. So be very careful with that one. It's kind of a little side point there. Anywho. You mentioned intranasal fentanyl is really good when you have no IV access, so that's a very common one we're starting to see used more and more nowadays. And in fact, I'll be talking about that tomorrow if you guys are at the research block. So it's about picking your patient's nose when you should do it. Anyway. Remember, the dosing needs to be pretty much individualized. You need to start low and go slow. Again, you can always give more medication. You cannot take it back. Okay, so if you're not sure, give a small dose, see how they respond to it, then you can always give more if you need to. Now, conversions are oftentimes necessary. So for instance, you have a patient who is on, say, extended release oxycodone plus immediate release oxycodone at home, and then they get into a car accident, you have to bring them into the surgical ICU, and now you want to put them on a morphine drip, IV. Questions of, well, how do you do that? Because you want to make sure you're addressing their initial pain concerns, their chronic pain issues, in addition to dealing with their kind of new issues. And so there's a lot of conversions that get built into this. And so I'm not going to have you do a bunch of calculations on how to do the conversions necessary. We'll walk through some examples, but just know that these need to be done. And a lot of hospitals will have guidelines to help you figure out how to make those conversions. Because the problem is if I convert and give them too much, then I run into toxicity. If I don't give them enough, then you can run into withdrawal issues and their pain's not really being adequately managed, right? So especially as it comes into issues that they are MPO, they need to go back on to IV, something like that, or if they're having any kind of changes where maybe their insurance doesn't cover one product, now they're switching over to another one. You may need to do these conversions. So to be very careful, and I'll kind of show you some tables here in a second. And then one of the things to consider is this idea of incomplete cross tolerance. Basically, when you make a conversion, drop the dose down by about 25%. That way, the patient is not kind of fully used to that new drug. It will, you won't kind of snow them. You won't make them kind of really too CNS depressed. So always drop that dose by about 25% or so when converting them over. Because again, you can always give more, you can always go up. You don't want to give too much initially. Okay. You have to include all sources of opioids. Look at their long-acting and their immediate release breakthrough doses as well. Okay. So here's an example of an opioid conversion chart. Again, you don't have to memorize this, but just to give you an example of what you might look at and when converting from one to another, especially if you work with hospice at all, you'll be doing these quite frequently. Hopefully they'll have a nice inpatient or a nice pharmacist there who can help you out with it if you have any questions. But and again, always call your pharmacist if you have questions over this stuff because it's very easy to screw up. Basically what you're going to do, and again they have a nice golden rule here, whenever changing you convert from the opioids they're on to morphine first. So basically convert them over to a morphine equivalent, and then you can convert them over into whatever else they want to go to next. So for instance, if they're on say oral oxycodone, you can see here that 3.33 milligrams is equal to 5 milligrams of oral morphine. Or like 1 milligram of oral hydromorphone is equal to 5 milligrams of morphine. And so this is good to kind of see the difference in potencies between these. So for instance, if you're looking at fentanyl here, so they're on a patch, 6 micrograms per hour, so again, very small amount, is equal to about 14.4 milligrams of oral morphine. So you can see just how potent fentanyl is in comparison and why you don't want to screw up that conversion. And actually I've run into some issues where I've had someone put in like actual 1 milligram of fentanyl before, which would probably kill most people in this room, I think. So again, be very careful with fentanyl. Make sure that the units are correct. I'm going to go between milligrams to micrograms. But basically, you convert whatever their 24-hour total doses. So you take all their extended release preparations and then on average how many breakthrough doses they're taking, add all that together, and then convert that over to a morphine equivalent, and then you can switch it back over to something like fentanyl, right? Or switch it back to hydromorphone or whatever you want to convert it to. And that can be, and then of course drop your dose by about 25% and then start them on that and then see how they respond to it. That makes sense? So let's say, for instance, here is an example. Say we have a terminally ill lung cancer patient, and they are taking their pain medication. The current medication is OxyContin 40 milligrams every 8 hours. Okay, so it's a pretty good dose there. And so basically what you end up doing is converting him over to parenteral hydromorphone. Right, so you want to convert him over to IV Dilaudid due to maybe he's NPO, maybe he's for whatever reason you need to convert him over. So basically you kind of determine what his total daily dose is. So in this instance, he'll be on 120 milligrams of oxycodone a day. You can convert him over to oral morphine. So here we see that oral oxycodone is about 1.5 times more potent, right? So you need a smaller dose there, and you convert it over, you get about 180 milligrams of oral morphine. Okay, so that equivalent dose of oral morphine to what he was taking of oxycodone is 180 milligrams. Next, you can convert that to IV hydromorphone. So again, using that conversion there, you'd say, okay, 180 divided by 20, because it's 20 times more potent, you know, 9 milligrams of IV hydromorphone a day. And so you can then divide that up. You could either do it as a continuous infusion, you could do it as intermittent doses, but roughly he's going to need around 9 milligrams. You're going to probably cut that down to maybe, say 6 or 7 milligrams, and then see how he's responding. And I can always give more if I need to. I can always adjust that dose up. That make sense? You always convert to morphine first, and then convert over to whatever else you want. Okay, so, what, 10 minutes left? Okay, so I mentioned patient-controlled analgesia, or PCAs. This one is being frequently used, especially in the post-operative setting. And so basically what it is, it's going to be a pump that you will have giving a continuous infusion to the patient. So we're going to call this a basal rate of drugs. So maybe for, say for instance, for morphine, you'll have, say, 1 milligram every hour being given, okay? So it's a continuous infusion. And then the patient will have a button where they can hit and get an on-demand dose, okay? They'll hit the button, and then they will give them, say, half a milligram or give them a milligram, whatever. The important thing here is, do you think if every time they press it, they're going to get a dose? No, because they could kill themselves that way, right? And it wouldn't be good. So basically what you'll find is there's going to be a lockout interval, where basically there will be a certain period of time where they cannot get another dose. So maybe 15 minutes, maybe 20 minutes. And so that way they're having a basal rate. They can give themselves a dose whenever they want to, whenever they feel like they need it. And so what that's actually found to do is be opioid sparing in general. So instead of the nurse having to come in and make the assessment, yeah, it looks like he's in pain, or especially if they're being really annoying and be like, oh, this guy's just such a jerk, I'm just going to give him a dose, shut him up, right? Versus the patient can just hit it themselves when they need it. You know, we try to avoid kind of abuse of the product by putting that lockout in. But hopefully that will decrease the total amount of opioids they need, then recover faster and get out of the hospital. Okay, so we're using this very frequently. It's very good. What's actually nice is you can actually check to see how often the patient's hitting the button. Because if they're hitting it pretty frequently, what does that tell you? Yeah, they're in pain. Maybe they're not getting enough, right? Kids, it's not always the case. We had one patient who was hitting it, I think, 300 times in an hour or so. I don't think he was in that much pain, but he was just having fun pressing the button. So go figure. But that can be very useful information, right? Or if they're not hitting it at all during, say a 4-hour period, what does that tell you? Maybe their pain's too well controlled. Maybe you can actually go down a little bit. Maybe you can decrease that basal rate a little bit, and that way they are on even fewer opioids, right, and help them mitigate some of the side effects. So a good example might be of an order you might write for a morphine PCA would be morphine IV PCA, 1 milligram per hour basal rate with 0.5 milligrams every 15 minutes on demand. Okay, and that way the nurse, when she goes in, she can program the pump and have all those regimens on there, and then you're good to go. Okay, and I've actually had some students, you may think, oh, I'm never going to do this, but I've had some students on surgery rotations who had some of these on their notes, and I was looking at them and was like, okay, well, how'd you write that? And so it's good to at least have some exposure to that. Make sure you have all the components there, because if it gets programmed in wrong, then that can be an issue. Okay. Patient either gets way too much of a basal dose, or the lockout's not put in correctly. They can give themselves too many doses. You can see some errors there. So here's an example. You put the medication basically into the pump here, and they'd have the button that would be available to them. Now there are some, some people maybe a little bit more savvy to some of these things and may try to reprogram the pump themselves. Oftentimes they will have usually a code the nurse will have that they can put in, or have like a button on the back of the pump they can hold in to lock it, so that way the patient can't mess with it, or family members can't mess with it. And usually these are locked up, so they'll have like a key the nurse will bring in to actually get access to the medication, so no one can like go in and steal it or something like that. Okay, so remember the full order, which you might expect here. Usually what we'll end up doing is having a 4-hour total amount, and so usually you just kind of calculate that out based on their basal rate plus how many demand doses they can get. So that way we can actually backtrack and make sure that it actually makes sense based on what the provider wants from the pharmacy standpoint. So anyways, it's very good. Helps to reduce opioid usage for your patients, and helps them to have a little bit more agency in their to kind of manage their own pain. Who do you think this might not be a good option for? Yeah, so elderly, like, so maybe people who don't have the cognitive ability to manage the PCA. So, for instance, like very young kids, very old patients who maybe their mental status isn't quite all there, or if they're like they're sedated and intubated, they probably don't need to. They're not gonna be able to hit the button themselves. It's really important to make sure that you don't have caregivers trying to press the button for them. They make sure it's the patient actually doing it, because otherwise, if like my kid was in pain in the hospital, I'll be like, press that button, press it. She's like, I don't need it. Keep pressing it. You're in pain. I can tell. So you run into issues like that where you want to make sure that the patient's the only one kind of managing that themselves. Okay, does that make sense? So again, very frequently being used in a lot of cases, especially in the post-operative setting. Okay, so just remember that from the kind of the Pearl standpoint here, typically your on-demand dose should be about 1/4 to 1/3 of the basal rate in most cases. Again, you don't want it to be the same. Get it down a little bit. And again, look at how many times they're hitting that button, because I will tell you if you need to go up on your dose, or you can potentially go back down on it. And so that's kind of what I mean by here, by actual PCA usage. That's how you should kind of address and change your dose there. Let's see. Okay, so adverse effects. Let's see how much time I only have 2 minutes. I'm not going to cover that right now. I'll leave you on the edge of your seat for next time. You think, wow, these opioids are so good. What is the drawback? Next time in farm. Any questions so far? Nope. All right, I will see you guys whenever next class is. See ya.